Welcome to Trying to Conceive with Dr. Sasha Hakman, where we break down the science of fertility, share real patient stories, and explore the latest innovations in reproductive medicine. My name is Dr. Sasha Hakman, and I'm a double board certified OB-GYN and reproductive endocrinologist and infertility specialist. I practice at HRC Fertility in Beverly Hills, but this podcast is an independent project created and hosted by me, separate from my clinical work. Don't forget to subscribe so you never miss an episode. And if you want exclusive updates and resources, be sure to sign up for my newsletter. Just click the link in the episode description. So in today's episode, we're going to talk all about the use of artificial intelligence in the field of reproductive medicine. We'll discuss the role of AI to optimize and analyze IVF medication protocols, analyze embryos for embryo selection, as well as evaluate sperm and egg quality. We'll also touch on the ethical considerations regarding using AI for fertility treatments. So Dr. Hariton is my guest today. He is a certified OB-GYN and reproductive endocrinologist and infertility specialist. He earned his medical degree from Harvard Medical School and an MBA degree from Harvard Business School. He then completed his residency in OB-GYN at Brigham Women's Hospital and the Massachusetts General Hospital in Boston. After this, he moved to San Francisco Bay Area, where he completed his reproductive endocrinology and infertility fellowship at UCSF. He currently practices at the Reproductive Science Center of the SF Bay Area in Oakland. Throughout his residency and fellowship, he has participated in clinical leadership committees with an emphasis on diversity, inclusion, and clinical quality improvement. He has over 70 high-impact academic articles, abstracts, and presentations that reflect his work. Dr. Eduardo Hariton is particularly interested in using cutting-edge technology like artificial intelligence to enhance IVF results, and is aware of the significance of providing the most cutting-edge, scientifically supported therapies. Welcome.
Thank you so much for having me.
Thanks for taking time out of your busy schedule. I'm really excited to talk about this because I think that not everyone knows, in all other areas of life, we're starting to use AI, but not everyone is aware that we're also utilizing it in fertility treatments.
Yeah, no, it's the beginning. This is the startup era of AI and IVF, but it's exciting to think about what it might look like in the future.
Yes. So tell us more about what are the current applications for AI for treatments like, for instance, IVF or even just the fertility evaluation.
Yeah. I mean, I think first, when I think about it, I take a step back and I say, like, how do we practice medicine? We've grown a lot in the last 45 years since the first IVF baby, but the process looks kind of the same. You come into a clinic, you wait in line, you pick up the phone, you make an appointment, you show up, you talk to your doctor, they send you away to do a bunch of different tests, and you come back, you talk some more, they decide what's the best protocol, and then you go through this treatment with multiple touch points. And at the end, we've gotten much better at giving people what they want, which is help building a family and success rates. But that end-to-end process hasn't really changed at all. And the decisions are still being made by physicians who have to aggregate more data, more variables, more tests each time, and we get better and better, but we still have these patients where it doesn't work as well or they really struggle. So the real opportunity to use AI or artificial intelligence, in my mind, is to take a step back and say, how do we re-envision this protocol? How do we bring all this data that humans are just not aware enough to analyze that quickly and that precisely to make better decisions for those patients? And that can be anywhere from the beginning, like, what tests do you need to do? And, have that patient come ready and prepared for that first conversation with the data so that you and I can help them make the right decision and break it down for them. That means saying there's like 5 protocols per clinic in the ones that,
right,
standardize it. And there's like 50 plus protocols across the country, people doing different things. Like, which one's better? Does it matter? Which one's right for this person based on their data? How do you put them through treatment? The meds are $3,000, $5,000 of your cycle cost. Is there an optimal dose, or are we just like slamming people with medications where if all the receptors are already occupied, not going to make a big difference? So how do we optimize that dose to make sure that we're giving them the best outcome possible, but also managing those costs? When do we trigger? And when do we trigger not only what's best for the patient, but also smoothing out that lab? Because we know if the lab gets overworked, that might impact outcomes. How do we pick the sperm? How do we pick the right embryo? And what does that look like long term? So it's really taking all of this input data that we're really good at capturing. The beautiful thing about fertility is that we have one single goal, which is get that patient pregnant.
Right.
That is much easier, and that's a very tangible outcome. So how do we take this process end to end to be better and more precise and more successful at giving people that baby is where the opportunity really is.
That's amazing, because there's so many pieces throughout this entire journey from, deciding the evaluation for infertility, for instance, hasn't really changed much over the course of a very long time. And of course, there's some basic workup that needs to be done, like evaluating whether or not the fallopian tubes are open, how sperm looks like, what is the ovarian reserve, not that correlates to likelihood of pregnancy, but just sort of getting an idea of ovarian function, and then hormonal health in terms of thyroid function and elevated prolactin, whether that's abnormal or not. But the way we even look at sperm for a semen analysis has changed somewhat. So, in your own experience, have you been using any form of AI or even just like the semen analysis?
I mean, I think not necessarily for the semen analysis, for example. One of my jobs that we didn't talk about, I see patients, same as you clinically, but I also work for a parent company, and I run the Innovation Venture Capital Fund from a company called US Fertility. So I get to look and meet with a lot of innovative companies looking at sperm and saying, like, we pick the sperm that swims fast, we mobilize it, we put it in, we don't think about it too much. But like, is there a way to pick a better sperm that, we know men are 50% of the genetic contribution to this process. So how do we pick the right sperm in the way that we pick, the eggs and pick the embryo? So how do we look at that? And there's a lot of companies looking at this, not any that we use in practice right now, but I don't think that that's going to be long term. I think we're going to definitely, look across a whole sample, not just one or two field, which is what the embryology does now, but look across a whole sample and pick, like, what are the sperm that have the right movement, the right morphology? How do you immobilize them correctly, and then get them into the egg? To your question of like, what do I do today with AI? So one of the things that I'm really interested in is building the right counseling tools to help patients make the right decisions. We look at a patient and say, oh, you're 35, this is your ovarian reserve. I think this is your chance of success. But if we have a patient yesterday that had an unexpected bad outcome, we're going to be a little more conservative because we're going to have that availability bias. Or if we have a string of successful pregnancies, we'll be more optimistic because we'll remember that pregnancy that beat the odds. Yeah. And that's just being human. That's not a problem. We're doing the best that we can. But when I look and I say, that patient in front of me, I want to give them the right data for a couple of reasons. Number one, I think it's the decision of doing IUI and IVF is very unique to every patient. And I think it's important to understand for expectation management, what's the likelihood that they're going to be pregnant? So we use this tool, we call it the AI Path to Parenthood. We build it in our company with our own data for our patients. And we put their demographics, we put their ovarian reserve, we put the sperm if we want to put it in, we put their diagnosis, and it pulls from different patients across our whole network, which is large. You need a lot of data for this. Yes. And it says for patients that look like you, your likelihood of success in the first 3 IUI cycles are like 7, 13, and 21%. Your likelihood of success for IVF cycle are 47%, 65, and 82. And you talk to that patient and it gives them how many eggs they can expect to get on average, how many embryos, how many euploids if they do PGT. And I can sit there with a patient, I can say, this is not my guess. These are people that went through this and have gotten this outcome. Let's talk it through. What does this mean? It means that you should be prepared. If you try IUI, then 1 in 5 times you'll be pregnant, and most likely you'll need IVF. It's totally okay to start there, but you want to go with the right expectation. I'm really hoping you're in that 45% that first cycle. But for most people, it will take more than 1. It makes my conversation when 45% of people fail that first cycle a little bit easier. I say, I'm really disappointed that you're not. I was really hoping you would be, but don't lose hope. We knew this was going to be a multi-cycle process. I still believe that, we can learn from this first cycle. We're going to tweak a few things that I think we could do better, but most people that stick with me will end up being pregnant. And it helps counsel that patient. It gives patient data. It helps them prepare emotionally, financially. And it's a tool that's super useful because it's not me guessing. It's really giving patients the information that they need to make the right decisions. I like to be the roadblock. I'd say, this is not safe. This is not a good idea. This is not going to work. But here are options that are all reasonable. And the patient and their partner, if they have one, can decide based on the information what seems like the right treatment for them, but also set the right expectations for the future. And we found it to be really powerful.
That's incredible. I really believe that counseling is the most powerful tool that we have to allow patients to be able to continue on that journey. And even yesterday, I don't know if you attended that talk, since we're at a conference right now at PCRS, there's that discussion that one of the most common reasons that patients will not get pregnant is because they quit. And typically it's due to the emotional strain associated. And I think a big part of that is if you're not setting the right expectation from the beginning and you go into this feeling extremely optimistic, like, okay, I'm doing IVF, therefore I will get a baby. Mm-hmm. And that doesn't happen the first time, you feel pretty gutted. And it really changes the way that you're able to sort of bounce back and move forward. And I think that if you you give those numbers, you set that expectation from the beginning, it makes it a lot easier to digest if things are not successful the first time, which they really aren't always successful the first time or even the second time. So we wish it were the case, but that's not reality. But I love that you have this data to be able to provide to patients, which is amazing. Using this information and having such a large pool of patients and data, how are you able to extrapolate that to try to optimize the IVF medication protocol? Because at this point in time, I feel like, and I don't know if your experience was different in fellowship training, I feel like most of us during training, it's a lot of each and every attending is sort of doing their own thing. Unless you're in a place that is more standardized, and the dose is sort of guessed based on age and ovarian reserve parameters. And we don't actually know, like, if you are in this category, this is your exact demographic. What is the best protocol for you to maximize outcome? And I'm not just talking about egg number, but live birth rate, which is the ultimate thing that we're seeking. So what have you guys had any ability to look into that and even use, neural networks, for example, to maximize or optimize what the IVF medication protocol should look like?
That's a great question. I mean, I'll say when I was in fellowship at UCSF, one of the studies that we did, we were trying to answer these questions like, does the protocol matter? And we were very lucky. We had a high volume center. We had 5,000 patients that did 2 IVF cycles within 12 months of each other. Just by chance, half of them changed protocol and half of them did not. So we had a cohort that did 2 of the same. It wasn't randomized. It was just retrospective. Just happened to work out like that. Wow. That some people repeated the same protocol and some people switched the protocol. And we had people that went from antagonist to long lupron to flare to antagonist. Everybody went in different directions, right? And what we saw was, it didn't make a difference if you switched or not. The outcomes were the same. When people didn't do well, meaning poor FERT or put blastocyst conversion, the second cycle, they did better, but it didn't matter whether they switched or they didn't. And for the most part, it was all about the same. So the conclusion of that, and it was like a landmark paper and people looked at this, was the protocol did not matter. And we like to think it matters, because if someone comes and puts all this energy and all this effort and all this time and all this money, and they don't get the outcome that they want, and you tell them, we're just going to try it again. Like, the definition of insanity is to do the same thing again and expect a different outcome. And it's challenging because in fertility, that goes out the window, right? Like, you do a cycle, you do amazing, and you get aneuploid embryos. You go talk to a patient, like, we did so well, we just got unlucky. They're like, what do you mean we did well? I got nothing to show for it. I'm back at square one. So we want to think that these things matter. In that paper, it didn't show that it mattered. But what I'm hopeful for is, like, that paper was looking from 30,000 feet. Like, I want to know if you know every demographic variable about that patient when they got their first period, what their menstrual cyclicity is, you know their coexisting conditions, you know the semen analysis, you know all of this data. Can you do better? If we integrate wearable data, we know what their HRV is, like heart rate variability, we know how they sleep, we know their heart rate, we know their temperature. Like, can we get better at this? I think when we start adding a lot more variables, we can think about that as doctors. We can be like, okay, like, 27-day cycle, I'm going to start on this protocol instead of that protocol. We just do not have the capacity to process the same. So we use heuristics. We try to think about, based on endometriosis, I like this type of protocol. It's a little more suppressive. And we do that. And it works most of the time because we're good at our jobs and our technology is good. But I want to get really granular with a lot more data and have some of these, neural networks really dig into those problems and understand if there's a difference. I don't know if there will be, is the answer. But I think that if we're going to find them, we're going to find them by putting a lot of data and trying to understand, is there really a difference? And if there's not, then why are we adding all this variability? It makes our nurses go crazy. It's confusing for patients. If it doesn't make a difference, we shouldn't be adding this complexity, because ultimately it creates cost. And that cost is passed on to patients and it makes access worse. So from a protocol standpoint, we'll find out. But right now, there's no kind of great data as to like, this is better than that. It's more, hey, what happens after that first cycle? I think one of the really unique things is not, let's guess the best protocol to begin with, but like we expected 9 eggs and we got 5, right? Is that because this month wasn't great? Or is there something about this person that we now need to tweak? So we learned so much from that first protocol. And do they get mature eggs from like 14s or 15 millimeter follicles? Do their big follicles get too big? Was the recovery harder? Did their estrogen plateau? I want to use that information to say, if your expectation was 9 and you got 5, and this is how the cycle went, how do I tweak my second cycle? That's a huge opportunity to get better. And I do think there's probably going to be something there that we can learn. On the dose side, you're exactly right. You're like, reserve is this, age is that. Let's start here. We can always adjust up or down later. Right. And it's our best guess. But when you look at, this is a study we did with a company called A-Life, where we looked at the dosing, and there are people that are dose responsive and there's people that are dose non-responsive. Meaning, for some people, whether you give them 300 total units or 450 or 600, it doesn't make a difference. So you're essentially making their P very expensive by giving them these very big doses of meds that their body doesn't respond to differently. So you can bring those people down to a lower dose without compromising the outcome and making sure they still get the same number of eggs. And then you had these responsive people that were like, if you give them 300, they get less eggs than if you give them 450, but then essentially they plateaued. So when you look at this and you say, can I optimize the dose to the outcome without maximizing it, but minimizing that dose, that can present a huge cost savings for patients, and it will still yield the same outcome. So obviously, these things are created somewhat retrospectively, meaning we look at data, we make our best guess. We got to make sure that it actually holds true in real life. And we're seeing those cost savings, but that's a great opportunity to apply a technology and say, knowing everything I know about this patient, what dose should I give them to try to maximize the outcome while minimizing the cost to them?
That's amazing. And I also love that you brought up this sort of more, for lack of a better word, holistic approach of getting more data in the sense of looking at HRV, looking at sleep patterns, because we tend to sort of get tunnel visioned when we think of fertility and reproductive health. We think of just the HPO axis, which, is the hypothalamic pituitary ovarian axis, where the brain communicates with the ovary, and sort of ignore other aspects of health. What is cardiac function? What do other health parameters look like, and how do they impact response to medications, and what the outcome of fertility treatment cycles look like? So I think that would be really interesting to put all of that together, get more information about other markers of health and how that impacts reproduction, because it's all linked at the end of the day.
And if you think about it, like 50 years ago, all care happened within a hospital. Yes. And then it went to an ambulatory center. Mm-hmm. And then it went to the One Medicals of the world that you can book on your phone and do telemedicine. And now it's in the home. So we're progressively moving and making technology more accessible, closer to the patients. The reality is our patient does a 2-week IVF cycle with us, and we see them 4 times, 5 times, for 15 to 20 minutes. Most of their day and their experience happens outside our clinic. And we have no window into this unless they call us with a side effect. What would happen if we get to understand how people are doing? One of the challenges of what's a good day to start a cycle? We don't know. Sometimes we tell patients that don't respond well, like, hey, this just wasn't the right month. You're not responding well. I know you can do it better because the last cycle 2 months ago was excellent. This one's just not as good. But is it a bad month, or when should we start? We don't know. It's kind of trial and error. Yeah. It would be wonderful to say to someone like, hey, based on your demographic, based on your heart rate, based on, all these things that I'm seeing, I don't think this is going to be the best month for you. Let's not be 1 week into like these expensive drugs and visits and the emotional ups and downs that come with that. Let's push it out a month. That would be the holy grail. If you could help a patient understand when to start and what might not be a good month before it happens, that would help us save a lot of waste, save a lot of time, save a lot of emotional energy, and get the patient the best outcome possible. And we've studied AMH, we've studied an antral follicle count before we start, we've studied inhibin B. None of them are predictive of success, so we just kind of have to start and see what happens. But I think as we think about asking this question with more data, you're exactly right. It's thinking through what else can we capture within the home, and can that help us predict it? And I think over the next couple of years, we're going to see a lot more of that research coming out. And that's really exciting.
Yeah, that is really exciting. I'm looking forward to that. So, what comes after our piece of it, as the physician, what we're really controlling is when to start, the protocol that they're going to be on, the actual procedure of the egg retrieval. But then once we get the eggs, really the embryology team now takes over in the laboratory. So what are the most promising AI tools in the embryology lab? Because I always say you can have the best doctor, but if you don't have a good embryology lab, then it doesn't mean anything. You need a good lab for really good outcomes. So, and to me, a good lab is not only having very skilled embryologists, but sort of having the latest, greatest technology to provide you the best tools possible for better outcomes. What are your thoughts on that? And what are the various tools that you think are really, really helpful in the lab?
So I think before we get to the lab, we got to trigger that patient, and we have to decide when that happens. So those trigger assisted tools, my thesis was, can I predict the perfect day to trigger? Because we're always like, trigger today, trigger tomorrow. You ask a bunch of people. Do you push
or do you not push?
Do you not? Yeah. And sometimes it's like, I could go either way, but I would love something that helps me be evidence-based.
Yeah.
And if you could go either way where it really makes no difference, then what's better for the lab? Because you want the lab to have smooth capacity. So we think about optimal day for patients. Outcomes comes first. If we have to do 15 retrievals, we'll do 15 retrievals. Because if that's the right thing for the patient, that's great. But if 3 of those retrievals have equivalent outcomes between today and tomorrow, why have a 15 retrieval day and a 4 retrieval day? We should have like 12 and 7 and have that capacity in the lab, because the embryologists are going to be less tired. The physician's going to be less tired. And we know when we overwork people,
they don't do as well.
Exactly. So the optimizing trigger dovetails really nicely into optimizing the lab capacity, and saying there was a really good study that came out that said in a 4-month period, you have days that are out of range too busy, like 15 times. But if you applied AI and would like what we call level load the lab without damaging any outcomes, without changing the yield any more than 5%, which is what we count as equivalent, you would have only a couple of days that go above that. And there's always going to be busy days, because that's just what we do. There's some randomness to this. But if we can take out 70, 80% of that variation and smooth out the lab capacity, the patients are going to do better. And they're still going to be optimized there. So getting those eggs out, we can get more eggs and better eggs and more blastocysts. And that's what multiple studies have shown, that trigger tools can assist physicians in doing this. And then you get those eggs to the lab, right? So you have an egg and you have a sperm, and that's how you make an embryo. I think, one thing that there's been a lot of investment in is imaging technology, either imaging of eggs to try to predict how many of them would make embryos. I find that really exciting. I take care of a lot of egg freezers who freeze a number of eggs. And I can say, on average, with the 14 eggs you froze, you can expect this. but I don't know if you froze great eggs or not so great eggs.
Right.
All we know is how old you were. So sometimes it sets you up for a disappointment when you try to grow them a couple of years later and you don't do as well as you expected. And it's not perfect, but there are some technologies that look at that and can help the patient say, well, I expect on average it would be this, but looking at your eggs, which there's no grading scale from using computer vision, we expect that you might do a little better than average or maybe a little worse. And that can help drive a different decision on whether we need to freeze more than those 14. Maybe we do another cycle, or maybe we fit good with that number. But we can give patients more personalized data as to what that looks like. Same thing on the embryo side. We have embryos that have been graded with a very simple scale, and that's how we choose them. We do PGT, or pre-implantation genetic testing, to figure out which ones are predicted to be euploid or aneuploid or somewhere in the middle. And then we prioritize them based on their genetic makeup to try to get people pregnant faster. But you have 2 million pixels in an image that you can look through an embryo and say, what else is there? What else could there be?
Yeah.
And it's either from a time-lapse machine that takes pictures of them as they go through, or maybe it's a single picture later on. There's different systems, but the ability to not only predict based on genetics, but look at the embryo a little bit deeper and see if there's something there is exciting. And there's multiple studies and multiple companies trying to look at this problem as well. So those are two of the things we can dive into, like sperm selection and different things like that. Robotics in the lab is a hot topic. People who are trying to automate that lab so that we can increase our capacity, get more people through. But there's a lot of these technologies that are there. And people are always worried, like, does that mean the embryologists are going away? Absolutely not.
Okay.
I think that, jobs are going to change, and perhaps it matters less how they grade an embryo. You should automate grading of embryos to some degree, but it allows them to do other tasks that they're really valuable because they're very skilled. I 100% agree with you. We could not do this without them.
100%.
Today, I want to talk to you about a tool I personally recommend to my patients who are trying to conceive, Inito. Inito is the first at-home fertility monitor that tracks 4 key hormones, estrogen, LH, FSH, and PDG, using a single, easy test strip. And in just 10 minutes, it gives you incredibly accurate hormone readings, but without the stress of lab visits. Inito can help you detect your fertile window with precision, predict ovulation reliably, and then confirm ovulation has occurred, giving you a complete understanding of your cycle. This comprehensive hormone tracking becomes particularly critical when we consider anovulation, which is the leading cause of infertility and often goes undetected. Inito serves as an indispensable tool here, not just for predicting ovulation, but more crucially for confirming it. It achieves this through a sustained rise in PDG, the urine metabolite of progesterone. As a physician, I trust the data Inito provides. I use it to monitor how my patients are responding to treatment, and I can adjust their plans in real time based on actual hormone levels. So if you're looking to take control of your fertility with clarity and confidence, I highly recommend Inito. Head over to Inito.com and use my code TTC Podcast to get your starter pack for just $89. That's INITO.com.
So I'm curious to know that these tools are still considered experimental. So they're not readily available to everybody. Do you think that when the day comes that we have AI to help select or sort of give some sort of prediction for the eggs, if you're freezing eggs, or selecting the best sperm, or analyzing the embryos to help prioritize which one to transfer first in the hopes of sort of reducing time to baby, will this come at an extra cost to the patient?
I think it depends. It depends on who's providing the product. I think when you think about validation, I feel strongly that we need to put these tools through the right research protocols and make sure that they have a positive effect. A lot of the challenge in our field is we have a new technology, we have a patient where things aren't working, and they're like, I don't have 3 years to wait until we go through this study and figure it out.
Right.
I am willing to try this because I don't have anything else to try.
Yes.
And then we get these technologies that come in, they get widespread use, but they haven't been well validated. And we've seen that challenges, a lot of things get pulled back and say, when we do the studies, it actually didn't help, it just added cost. So when we think about AI, we have to think about validating it correctly not just rolling it out and hoping for the best, because that's not a good recipe for success. On the flip side of that, doing like a 500-person randomized controlled trial is really expensive. It's like millions of dollars. Right. You have to incentivize patients. You have to go through this process, recruit clinics. And these companies are young and they raise money and they don't have all this time to wait. They don't have the funding
for that.
So, there's some that have done it, which I really respect. There's some that say, I can't do that, but I validate it a different way. The regulatory path at the FDA level is also a little bit difficult because we're used to like having drugs or medicine go through this path. And once they make it through, that's a drug. It's not constantly changing. You're not changing the formulation. You're not changing anything. You know that the drug works in that current form. And if you want to change it, you go through that process again. AI is supposed to keep improving. Like when I talked about my predictor tool before, as my patients go through cycles, every month we get more patients in there. So the tool becomes better and better and then adjusts. So I might show something to a patient and the other day they're like, hey, last time you showed me this, it said this and now it says something different. And I was like, yeah, we've done a couple thousand cycles across our network in the last few months. So it's gotten more precise because there's more people that look like you that are coming into this prediction, right? So we want these AI tools to continue to get better, yet the regulatory framework does not allow us to continue to improve a tool. And if you put a tool through a 2-year study, it's obsolete by the time you're done with that study. It could be so much better. So it's a difficult problem. And when I think about what it might look for patients, it kind of depends. Like my goal for these tools is that they pay for themselves, right?
Got it.
Meaning if I have a tool that makes me 10% more efficient and it costs me 10% less to take someone through a cycle, I should be able to pay for that tool and keep my prices the same and let that grow. Some tools are not going to be value add or efficiency add, but there might be some things that the patient wants. So maybe we do pass that cost on through the patient. I think those are the kind of decisions where it's a very unique case. It depends on who's providing the tool, how much does the tool cost, who's it adding value to, and what does that look like? You don't want to kind of keep adding things to the bill and making this process less accessible. Technology should unlock productivity so that the cost overall is the same or goes down while the outcomes. So when I think about these technologies, I think of value. And value is outcomes over cost. So if a technology can lower the cost, it's going to increase the value. If a technology can improve the outcome, it's going to increase the value. And if it's costing me a lot more to integrate this technology that's not really moving the outcomes up, then it's going to lower that value. That's not something we should implement. So it depends on the situation. But my hope is that overall, this is not something that makes the process more expensive, but rather the more same efficient, with better outcomes or less expensive.
Yeah. Yeah. I think one of the hardest things about our field is that whenever there is innovation, we're always sort of trying to balance with the fact that patients want access to this newer technology, even if it hasn't been validated, because they don't have time to wait, particularly if they are older or if they've been really wanting a baby for a long time and nothing has worked so far. So what ends up happening is different companies are feeling the pressure of patients wanting this access. They make it readily available. People are paying a lot of money for it. And we don't even know whether it is actually making a difference or not, which is one of the greatest challenges. I think that we see that in every aspect of this field. And I think our field is sort of unique in that regard. So, I mean, I guess too, the AI would help us to better potentially grade the embryos, evaluate sperm. Right now, what we're just looking at for sperm selection in the world of in vitro fertilization is which ones are the strongest swimmer? Does it sort of look normal? And we use, the judgment of an individual to try to predict which one is better. But we really have no idea if it was even good sperm or not. So we might be injecting eggs with sperm that are not going to help yield a sort of embryo that will lead to a baby. So I think it's got a lot of potential, but obviously it sounds like it's still in its infancy. But it's always reassuring also, I'm sure, for the embryologist to know that AI isn't going to replace their jobs, but it might sort of shift the roles and the time spent in their different roles as well. Are there any other areas within our field that we're seeing AI really emerging and potentially making a big difference?
I think when you look at AI across the world, it's one of those things where it's changing the way that we work. Like it's changing the way that we analyze data. It's changing the way that we communicate. I think ChatGPT was one of those things where you think about it and, people knew it was coming and then all of a sudden it was out there and they're like, wow, I tried it Monday morning and by Monday afternoon, it was like drafting my emails. Like,
yes.
You're like, this is amazing. And it,
yes.
over the last year, it just keeps getting better and better and better.
And it gets to know you. So it knows the person who's typing things in and is catering to that.
Absolutely. And the reality is we spend a lot of our time communicating and we spend a lot of our time communicating the same things. And you and I have the benefit that we get to communicate verbally with patients, which is the satisfying part of the job.
Yeah.
But our staff and our financial educators and counselors, they communicate in writing with patients and they say the same things all the time. And they have to be warm and empathetic and timely. And as we take care of more people, it becomes harder to keep up with that communication. Our generation doesn't want to hear in 48 hours. They want to hear now. They want a text and a text back.
Yes.
So when we think about how do we support our teams to be able to do the best communication possible, we can think about like large language models or LLM, which are essentially the underlying technology of ChatGPT and, Anthropic and all these other companies that have similar products like this, and use that to communicate with patients better. We have all the data that we need. We've answered what are the side effects of HSG or, can I drink kombucha during my IVF cycle, or like is Tylenol safe or not while I'm doing my frozen embryo transfer? We've answered those questions. We know the answer, but let's help our teams get more efficient. Let's help our teams sound more empathetic and let's meet the patients where they are. Because you're right. It gets to know me. It gets to know you. It knows how we like to answer. It knows what lifestyle recommendation. Like I use ChatGPT and the patient's like, what can I do for lifestyle recommendations? I'm like, give me some bullets on lifestyle recommendations that I like. Boom, 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 boom. How to sleep, what to eat, data behind acupuncture, what are supplements that are validated. And it knows what I'm going to say and it adjusts it. We got to be really careful. I never put any patient data in ChatGPT because it's not HIPAA compliant, but it can help me create these messages that are thoughtful and warm to the patients. And it helps me get to more patients in a quick period of time. So I think it's really going to revolutionize the way that we communicate with patients. It's going to give patients access to high quality information quicker. And it's really going to help us take out that kind of very manual, but not necessarily value add aspect of communications and really help patients get what they need. And there are companies that not only do our side of things, but they interact with the patients and they capture from either text or voice, how are they feeling? So they know if the patient's coming across disappointed or anxious or stressed, and they can meet them where they are in that situation, acknowledge their feeling, which is a big part of our job, and then help them get the information that they need to feel in control. Because I think both of us know the hardest part about going through a fertility clinic is not the science or the medicine or the injections. It is the fact that most of our patients are used to working hard, getting a promotion, studying and getting an A. And they're doing everything right for 6 months or 12 months or years, and they're not getting the outcome that they want and deserve. And that is really disheartening. So helping patients cope through that by giving them better service and adding value, I think is another way in which we're going to support them using AI.
Yeah, and that's amazing. I love that you added just even communicating in a more just considerate way, being warmer, because although we always try to get staff on our team that is able to really empathize with patients, not everyone really can get on that level, especially via email. Maybe they can do it in person, but they may not be as equipped doing it in writing. And using AI even as a tool to really come across as someone who cares when you don't know how to put those words together in that way. It's like, I never really thought of that as using it in that sort of regard.
I mean, think about who, you typically select nurses and doctors for people who want to work with people and they like this communication. So they like people who are relatively high IQ and empathetic, want to come into these fields because they drive satisfaction. But the person who's doing billing and dealing with CPT codes is not that person. But that's a person that then needs to go and explain a bill to a patient who had a bad outcome and is trying to sort out insurance and this and that. Like that person's skills were not trained for like empathy, yet financial is a big stressor. So you want to support that person and say, I would love having you on my team because you're an expert and you do a really good job. But you have to understand the person on the other side of this is going through a really tough time. So how do you give them this financial estimate and all of these things with a dose of empathy, understanding that this is going to be a stressful component, making yourself available? And, I think technology can really help.
It's amazing. Where do you think is going to be the biggest sort of change with AI in our field for fertility treatments over the next 5 to 10 years?
I think it was Bill Gates that said, like, you over expect what you're going to get in 2 years. I'm totally butchering the quote, but it's like you always are overly optimistic of what's going to happen in 2 years. You're going to think it's more, but then you have no idea what's coming in 10 because that J curve's really fast. So I don't know what the timeline is, but I think the part that I'm really excited about is we're seeing across our country, more people have access to care, whether it's their employers or their states mandating it. There's this understanding that people deserve to build a family. Demographically, we live in a world where we are not, having enough babies, and that's multifactorial.
Yes.
Infertility, we don't support parents when they have a child. Childcare is really expensive.
Yeah.
The family has changed and people are having babies later, etc. But we understand that we are an integral part of making sure that whoever wants to have a family has the tools to do so. And we are making it more accessible. That means that we're going to have to take care of a lot more people. And our system is not currently designed to do that.
No.
So how do we do that? I think we're going to have to re-envision what that relationship looks like with the patient. I don't want to take care of 3 times as many patients and have them have a terrible experience.
Right.
I want every patient to feel like they have my attention, like they're my only patient. And I think technology will give us the opportunity to help more people without degrading that patient experience, that human touch. So if I don't have to do these manual tasks, if I do a 3D sweep of the ovary, we didn't even talk about ultrasounds.
Yeah, we didn't talk about the ultrasound.
We take 15 minutes measuring every follicle and this and that. And it's not always precise because you're going fast. You might miss one. They get bigger, they get smaller. You can do a sweep through the ovary and in 30 seconds get perfect follicular measurements and then, move on with your day. So all these technologies are going to allow us to take care of more patients more efficiently. I want to see that patient when I have data. So I would like them to get all their data before they come see me. My biggest pet peeve is we have the biggest block we have is with our new patients. You have 45 minutes or an hour, depending on who you are.
Yes.
But a lot of times you're having these conversations where it's like, we got to check your ovarian reserve. If you have a good reserve, we can try this. If you have a bad reserve, we'll try that. If the sperm doesn't look good, then we might need to do IVF. If the sperm looks good, we can start with that UI. Why not get all that data up front so we can have a real conversation about what we need so we can automate that workup, get that patient to come in ready to have that really valuable conversation and come up with a plan. Time to treatment goes down. We can optimize a lot of like our selection protocols and the dosing and things like that. And it's going to take a long time. This is not something where I think next year everything's going to go end to end. But I think thinking about these tools, the fact that we're doing the research to really say, how do we deliver a better patient experience? How do we automate tasks that we can do better on to make the process cheaper, make it more automated? It's not going to replace doctors because no one wants to talk to a computer when they're having a miscarriage.
Yes.
And I don't want my patients to either.
Right.
But I can go in there and spend the time because I'm not doing all these manual tasks and not charting all day in front of a computer. And I can actually spend the time with my patients at the inflection points where they really want me. Like I call every negative pregnancy test because you want to hear from your doctor.
Correct.
You want to hear from your doctor when you're triggering to tell you what to expect. And the more you can automate these parts of the process where you can do the same or better or the same or cheaper, the more time I'm going to have to really spend with those patients, pick up the phone and call them or pop by their visit, etc. And I think it's going to drive physician satisfaction. It's going to drive patient satisfaction, and it's going to expand our system and allow us to help more people who deserve to have families and are slowly having more access.
I love that. It's a really great perspective.
Thank you.
Now, with all of these tools that are emerging, and we assume that they're going to get better, they're going to be more accessible, it's going to be widely used throughout probably the whole world. Are there any ethical considerations for using AI? What are the different possibilities of what could potentially even harm a patient outcome or be considered unethical?
That's a good question. I mean, I think certainly we want to make sure that we're validating this to make sure that it works. I think it's unethical to just let it loose and see what happens, because you don't let a physician loose. You train them. They go through training. They go to multiple years. They're supervised. There's milestones. They take board exams. So before someone comes and is allowed to make medical decisions for you, they go through a lot of training and testing. Yes. And I think we should expect the same of our technologies, especially when they are costly. So I think that validation aspect, like we talked about, is really important. I think the other part is the technologies that use AI are only as good as the data that are underlying them. And not every patient's the same, and not every patient's from the same background, and not every patient responds the same to medication. And some of that could be biological, some of that is cultural, some of that has other factors that we don't even understand. So thinking through making sure that we build these tools in heterogeneous data sets, meaning they have white patients, Black patients, Hispanic patients, Asian patients, and all kinds of ethnicities, so that when my patients come through and they're using this tool, they're not using a tool that was built for a completely different population. Like one of the big value areas that we have in our data set is that we have 19 clinics across the whole country, and we have patients that are from the Southeast and the Northwest and the East. And some of them are low BMI, some of them are high BMI, some of them are, 25, 30, because that's the population that might see us in a market. And some of them are 40, 45. And using those all together allows us to get really good data and really good answers that we can generalize. But if we, when you do it from a single clinic, that's really not helpful outside that clinic at all. So I think one of the ethical things to think about is making sure, IVF used to be for the rich and famous. And slowly that's starting to change. So we want to make sure that we have data from all people, from all walks of life, from all ethnicities and backgrounds, to be able to build tools that can be used on those populations in the future.
Yeah, I think that's a really big deal. It's funny, I talk about it with my colleagues sometimes, where we try to exchange and see, our Asian patients, do they do better if we trigger at a certain follicle size compared to Black patients versus white patients? Like, what is the difference in what is optimal for each subgroup based on ethnicity? Because there are some genetic variations between us. And of course, I have to include Middle Eastern too, because, that always gets forgotten. But it's really interesting to think, like, how do the different backgrounds, ethnicities, if you're Hispanic, does that change for you how you should be treated with your medications, when you should be triggered, how things are going to look for you? So it's a really interesting perspective. And I like that angle of it.
And when you think about it, you might be smarter than me, but I just can't, I'm making 10 trigger decisions a day. You cannot process as a human fast enough for every patient. And remember, okay, so they are, last cycle they did this, and this cycle they're here, and their estrogen was that, but they're Middle Eastern. So I'm thinking I might want to go bigger. You cannot process all that information. But imagine something that knows everything you've done and every cycle and where you come from and how you responded last cycle. And it's putting that all in real time to give you a suggestion. And you're the doctor, so we have to make the final decision, at least in this iteration and for the near to medium term future. But we could definitely get help from something that processes it all and really distills all of those factors and says, the follicle size matters the most. The BMI matters a little bit. The protocol matters a little bit. So when we did these studies, we looked and we said, what are the features that really drive the outcome? So when it was triggered, follicles 16 to 20, the most important. Follicles 15 to 11, the second most important. Estradiol level, the third most important. Age matters a little. BMI matters a little. Type of trigger matters a little. So these all things matter. But it was really validating to see the AI is looking and using those same variables to make that decision, which is the same things that we're doing. So it means we're looking at least at the right things. Yeah. But if we move the needle 5%, if we move the needle 10%, that means that we're helping one more person have a baby out of 10. That is huge. That is huge. Really, really a big difference. And we are great. We're doing one embryo transfer of a euplate embryo, getting 60 to 70% pregnancy rates. It's hard to get much better than that.
Yeah.
But every couple percentage points just get you a little bit closer. And when you're taking care of so many people, like it makes a difference when you add those all up.
At the end of it, you've changed so many families' lives, quite literally. So it's amazing. If there's one thing that you're most excited about for the future of AI in the field of reproductive medicine, what is it? If you had to pick one.
If I had to pick one, I would say that across the board, I think that AI will be one of those technologies that allows us to scale what we do and be the best at whatever level you are. We see very big variations in how we practice, in what we do, in the outcomes in a good lab and the bad lab. And people are like, well, I have a bad lab because my patient population is different. But once you normalize for everything, you still see variations. Mm-hmm. So I think AI is a democratizing technology, the same way that the internet brought education to places that didn't have it before. So you could be sitting in a third world country, and as long as you can log on to YouTube, you can learn about anything. Mm-hmm. I think when you think about what it might do is it might help our clinics. If the bottom half moves to the middle or to the top, and we kind of narrow that difference and everybody does the optimal protocol at the optimal trigger, and we can get some of that, we're going to come together. We saw that happen before. Everybody used to make their own media and make their own needles and use this. And you saw huge shifts in success rates. Yeah. And now a lot of that has gotten commercialized, and the labs all perform quite well. Blastocyst conversions are on average relatively good, much closer than the way before. So I think we're even going to get closer. And all, the tide raise, I'm butchering all the quotes today, but like the tide raises all ships. I think that's going to happen with AI. I think it's going to allow us to take care of more patients better, meeting them where they are, personalizing the treatment for them, communicating easier. The fact that we have to call our patients to tell them what to take that night, and that is 2 to 3 hours of someone's job, when everybody has an iPhone or an Android and we could push a notification in an app. So these kind of technologies are going to help us make this process clinically similar, but more efficient, more effective, more scalable, and ultimately allow us as doctors to do what we love to do. Take care of patients, talk to patients, but help the people that currently don't have access have access.
Amazing. Well, thank you so much for this. This was really fascinating, and it's making me really excited for the future of our field. Can you just briefly tell our listeners where they can find you?
Yes, so you can. I'm not as a social media guru as her, but I have an Instagram at Hariton MD, and you can find me in the RC Bay Area page. And if anybody's there, I'm more than happy to help. But for those in the LA market, you have a specialist here. And thank you for having me today. It was a great conversation.
Thank you. Yes, it really was.